And we can see now we've got two nicely fitted cones here. We can see that dentin bridge, which looks fantastic. Off the excess through the dentin bridge using this broken or this bent heated plug is actually quite advantageous. Hello, so welcome to this week's Friday clinical case. This is another unusual access cavity, and I suppose in a way, you know, these types of cases come just kind of off the cuff. So these types of access cavities, shall we say, are access cavities that you're not too sure or you're not aware of you're going to make these types of access cavities until you remove all the decay and so you know. Essentially, I video all of my root canals just because sometimes you look at a root canal and you think it's going to be like a bog standard treatment, but actually once you get into the nitty gritty of it, something comes out that's quite interesting, and I think this is in this case. But before we talk about the case, what I want to say is that over 50% of the people who watch these videos on YouTube are not subscribers. So if I could ask you to do one thing for me, it's free, it's easy, and that's just to hit that subscribe button. If you love the channel even more, if you want to support the channel even more, I would say to you, join the membership program here on YouTube. You get early access to content. Usually I work about 3 to 4 weeks ahead with the content. So if you like these videos, you can get them early. And also we've got exclusive content. We've got a fantastic endo access lecture, which is about an hour long. And we've also got a new exclusive video coming soon, root canal for the newly qualified dentist. So we'll get on with the case. This is a seemingly innocuous case here. This is an upper right 5, and this is another external referral that was sent to me. The tooth was symptomatic. The referring dentist had taken an x-ray, and we found that there is a chronic apical periodontitis. And in this case, you know, we can see that there is an amalgam filling in this tooth, and a lot of the times, well, I've got two options here. I've got an amalgam filling. This has to be removed before I start the root canal. I could book in a half an hour appointment with this patient just to remove the filling and then place a composite filling and get the patient back in. I could ask the referring dentist to place a composite filling in there for me, although I don't think that's a practice builder. Or what I could do is I could do it all in one. But the problem is, of course, is the isolation. And if we move over to the video here, we can see that in this case, what I'm going to do is I'm going to do a multi-isolation attempt with this. And the great thing about using multi-isolation is that you get to isolate the tooth, but also, say I was just doing a single isolation, I couldn't replace the filling in an easy way. So if you are new to dentistry and you're thinking about what's the very, very first course you should put yourself on, I would say a rubber dam course for sure. I think the ability to place rubber dam in all situations is absolutely vital. So in this case, I am just making a few holes in the rubber dam, and I'm putting the holes in a place where I think where the teeth are. You can see here there's a bit of a space between the very, very back tooth and the other tooth. So in that case, I've made a bigger gap in the dam. And then in this case, I rather than going straight for the clamp, I'm just going to try a couple of clamps onto the very, very back tooth. I want to make sure that the clamp is nice and tight and it's going to fit nicely. I believe the very, very first clamp I tried doesn't work very well. So what I do is I just have a little look at the tray that I'm using. I look to see if there's a smaller rubber dam clamp, and then obviously I just pick this up. I have a little look, and now this one fits really nicely. And then a lot of the time with multi-isolation, what I don't tend to do is I don't tend to use this technique where I put the clamp on and then I put the clamp on the rubber dam and then I put the rubber dam and the clamp straight on together. Usually with multi-isolation, I actually put the clamp on the tooth and then I sort of squeeze the rubber dam over the teeth. But in this case, I felt like you know, there was enough sort of technique here for us to place the rubber dam and the clamp on at the same time, because it's quicker. And essentially what we do is we just very, very gently push the rubber dam over the teeth, and then we just floss the contacts and make sure you get a nice tight seal there. As you know, if you do multi-isolation, sometimes you need your nurse to kind of squeeze and push the rubber dam apart, but again, in this case, it's all done very, very nicely, just by myself. So we're now ready to remove the decay and the old amalgam fillings, and I'm just using a quick succession of fast hand pieces and slow hand pieces. And you know, again, if you're new to dentistry, the best way to remove a filling is just to undermine it, rather than drilling the whole thing out, which would take you forever and ever and ever. And sometimes it can be quite difficult to see where you are. What I do is I just undermine the sides of the filling, and then once I've undermined the sides, I can usually flick the pieces out. Or a lot of the time, what happens is the filling just flicks out by itself, just by the action of the fast hand piece. And it's at this point where I'm thinking to myself, you know, why is this tooth died off? And also we've got kind of a bit of a bridge of dentin in between these two fillings here, and I'm thinking to myself, you know, I wonder if I remove both the amalgam fillings here, and then I start to drill out with my slow hand piece. At what point and where is this pulp chamber exposed, and why is this tooth died off? And I'm also thinking to myself, you know, there's also a bridge of dentin here, and should I drill straight through the middle of this tooth, or could I get some kind of nice little sort of buccal or distal aspect of this tooth and try and save as much of the dentin as possible? And you know, we have a close look at this tooth now once all the decay and the fillings are removed, and we can see there's quite a significant bridge which has been kept between these two teeth. So I'm thinking to myself, I want to try and keep this. This bridge of dentin and bridge of enamel, because it helps with the structural integrity of the tooth. Although I think straight away I'm aware that the access on this tooth isn't perfect. So we're doing a little bit more refinement of the filling and the tooth, and just getting rid of all of the old filling and all of the decay, and just having a little feel around. Also, as well, what I'm doing is getting the fast hand piece, and I'm just slightly opening up the canal orifices, although you've got to be very, very careful when you do this, is because obviously this is a really, really small tooth, and you don't have a lot of leeway with premolars. You know, the chance to perforate these teeth are super, super high. So if you're not confident with a fast hand piece in a premolar, just be really, really careful, especially at the CEJ, because that's where it's quite narrow. So at this point, I'm looking at the canal orifice, and it's looking pretty wide, as if, you know, there's like, it's either ribbon shaped or maybe there's two canals. I'm not entirely sure. Obviously, the problem of me determining if there's two canals or not is compounded by the fact that there's huge bridge of dentin and enamel in the middle, and I suppose in a way, if you're not confident, you know, doing this kind of technique can make life much, much difficult for you. But essentially what I'm doing here is I am raking a hand file down the buccal wall and the palatal wall, and I'm working out where the hand file sits, and to see if this sits in a different position. Because if you've got one canal in a tooth, and then you're raking, and what I mean by raking is you're scraping the tip of the file, you're trying to sort of see if it where it lands. If you're raking it down to both the walls and it sits in the same position, it usually means it's got one canal. But if you're raking it down the two walls and it sits in a different position, maybe there's two tubes. And in fact, when we sort of push it down here and we look quite closely, we can see that the hand file kind of moves as it rakes down one of the walls. It moves into the center of the tooth. So I'm actually quite confident that this tooth actually is single rooted. Now we could take a cone beam CT scan. We could just remove the dentin bridge, but I think, given my experience, I'm happy that this tooth has got one tube. So we're going to do our working length check. I'm going to irrigate the tooth quite significantly. bit difficult to irrigate in this case because, of course, there's 2 holes in this tooth, so you just got to be careful where that irrigant goes. And then we're going to go straight for our working length check. And I'm using a size 10 K file here in the first instance. I feel like this is moving quite nicely to length, so there's not a lot of resistance in this tooth. And what I'm doing is I'm just ever so slightly kind of watch winding down into this canal space as I've got the apex locator hooked up, and I like to push the apex locator or the file through when the apex locator shows that it's out the end. You can see here I'm just going to push it forward, and then we go past 0, and then we're just backing up the hand file, and then that gives us our 0 reading. A lot of the time, sometimes if you're just not pushing it through the end, although what I would say is you've got to be careful, you can get a 0 reading and then go maybe 1 millimeter or even 2 millimeters more and have the same 0 reading. So in this case, I feel like I've got the correct reading. I'm just going to move the rubber stopper to a reproducible point, and then we're going to measure it, and the working length is found to be 22.5 millimeters. That's the 0. That's at point which the hand file is at the periodontal ligament. And then as we sort of irrigate this tooth, we can visualize this dentine bridge a little bit better now. And I suppose in a way I am thinking to myself, is this all worth it? Is the pain and the bother here? But I think in a way, when we mentioned before, the premolar is quite a weak tooth. It's kind of the size of an incisor, but takes the brunt of a molar. So I think any kind of conservative actions we can do on this tooth, any chances we can do to conserve tooth tissue, and also to try and stop any kind of wedging force on this tooth, or minimize any wedging force, I suppose in a way this is going to make the tooth last a little bit longer. So that's my kind of my justification for leaving this dentine bridge in place. We're now ready to shape the tooth. I'm going to get a glide path file. I'm using a 1504. And this is going to be at the 0 reading. It's going to be at 300 RPM, and the lowest torque that's available on this endomotor, which is 1 Newton centimeters. And I've mentioned before that if you're using a high torque on a glide path file, or you need a higher torque, it means that you're not using it properly, because the glide path file should be passively reaching the end of the apex. You shouldn't be pushing this, because if you are pushing it, you can file fracture or cause a ledge. And then it's just a quick succession of shaping, irrigation, recapitulation, making sure that we're being really, really careful, because we're not too sure what the end of the tooth looks like. It could be a tight bend, so just being very, very careful. I feel like the size 10 goes to length relatively easy, so I'm happy to use a size 25 variable high flex file. If I feel like the end of the tooth is a little bit difficult, then I may be thinking about using a lower diameter file. Of course, using a lower diameter file is going to get you to length much, much, much easier. And then, same protocol as before. It's a little bit higher torque, it's a little bit higher rotary action, but in this case, it should always be used passively. So there's no pushing these files to length. I think when I was newly qualified, I used to love shaping and pushing quite hard, but I'd made too many mistakes. So we look at the canal here, and it's kind of ribbon shaped, and I can see that maybe if we sort of annotate on the video here, that the ribbon shape is this kind of blue colour here, but the shaping of the rotary file is actually straight down the middle of the tooth. So according to the rules of Krasner and Rankow, I feel like the canal is in the center at the CJ, and that makes me also again happy that this is a single rooted tooth. However, I feel like to obturate these teeth, especially with this dentin bridge, it's going to be probably a little bit difficult. So rightly or wrongly, what I do try to do is I try and shape the rest of the ribbon canal space here. And what I'm doing is I'm trying to rake the rotary file down the palatal aspect of this ribbon shape. And again, doing these videos, we do a lot of reflection, and I think to myself, is this worth it? But I feel like, in a way, to obturate this tooth easier is for me just to shape it a little bit more and maybe put another GP code down, and this minimizes the risks of voids, and of course voids can cause failure because bacteria can proliferate in them areas. But we've sort of shaped the two kind of holes in this ribbon shaped pulp chamber, but when we irrigate and aspirate in these two holes, we can see that they drain both in the same hole. So we know that this is just one big kind of ribbon-shaped canal orifice. We're now ready for our cone fit radiograph. I'm going to get the working space area nicely set up. I am getting my hand file in our disinfecting ring straight away and ready to disinfect. What I don't want to do is start the obturation and then realise I haven't put the hand file in any disinfectant, because we need to place the hand file to length, because this is going to introduce the bioceramic all the way to the end of the tooth, and if it isn't disinfected, obviously you're just introducing bacteria into the canal space. And then we are just placing a couple of little cones in the middle here, all ready to go. And then we're going to pick up the cone. We're then going to measure this cone 0.5 millimeters away from the 0 reading we found on the working length, which is about 22 millimeters. And then we're going to fit this cone to length in the tooth, and then we're going to sort of feel for that kind of tug back. And sometimes, if you've left a significant amount of tooth tissue in the coronal aspects of this tooth, this might grip onto the cone or even the file. So you just got to be careful that this is going to length really, really nicely. And then we can see there's a little bit of a space between this GP cone and the palatal that we've shaped. However, I feel like the GP cone that I've already got out, which is another 25, is probably a little bit too wide. So I'm just going to use a smaller GP cone. I'm using a 20.05. This is another high flex GP cone. We're just going to check the diameter of this cone, and I'm going to place this into the palatal aspect. And I'm going to measure it to 22 again, because I'm still curious to see if there is a separate canal in this palatal, despite the fact that I'm pretty sure it's the same. But as we fit this GP cone in the palatal aspect of this cavity, this pulp, we can see now that it's a bit short. So we know that this is a single rooted tooth, because if it was double roots, this would fit to length quite nicely. And this is just hitting the 25 GP cone where it's joining. And then we snip off the excess, and we look at the cone fit, and it looks gorgeous. Oh, it looks beautiful. It's going right down the center of the tooth. And also we can see here on the cone fit that we can actually see the two cones at the sort of CEJ, and it looks pretty neat. We're then ready to do our obturation. We're going to prepare our disinfectant ring. I'm going to place the disinfectant into one of the wells. This is where the hand file is. We're then going to place another disinfectant in the palatal well, and then we're going to use 17% EDTA, and then we're going to use isopropyl alcohol. We're then going to remove these GP cones. We're going to place them in the disinfectant ring. We're going to make sure that these cones have been disinfected appropriately, because don't forget they're not sterile when they come out of the box. The box is just open to the elements. And then we're ready for our final irrigation protocol. We're going to fill up the cavity. I'm going to use this 18th Ultra X activation unit here. I like to use it on the 2 dots, which is the highest activation level, and then we are just going to activate our sodium hypochlorite in this canal. The second rinse is going to be 17% EDTA activated. Final rinse, sodium hypochlorite activated. We're then ready to do our paper point drying. I used to like to use these Wave 1 Gold paper points because they're sterile. The high flex paper points that we use aren't sterile, and then we essentially just place the paper points to length until the ends of the paper points are super nice and dry. We're ready for our final obturation. So as you know, I like to prepare everything. I like to prepare the GP cone first. We're going to dip that in isopropyl alcohol, get rid of all the residue of the sodium hypochlorite off this GP cone, and we're going to just air dry it. We're then going to crimp the tweezers, and we're going to place that to one side. We're then going to prepare our hand file again. You know, you could dip it in sodium hypochlorite, but in this case, I'm just blow off the sodium hypochlorite and just air drying it. And then we're going to get our one fill, our Bioceramic. We're going to put a visco tip on the end, and then we are going to load this visco tip ready to go. And then everything's set up then. We're going to move over to the tooth. We're going to obturate the main canal here. We're going to get our visco tip. We're going to directly inject the sealer into the main canal here. We're going to backfill this again. I say it once, say it 1,000 times. I can do this because I've got high magnification. Once we're happy we've got enough sealer in there, we're going to pick up our hand file, and we are going to push this to about a millimetre away from the working length and just introduce the Bioceramic to the whole length of the tooth. We're then going to pick up our prepared GP cone, and then we're going to just very, very, very gently push this GP cone to length. And what I'm looking for here is two things. I'm looking for the bit where I have cut the GP cone off is going to marry up with the point at which we've measured our working length. And also I am keeping a keen eye on the palatal aspect of this pulp chamber just to see if this fills up nicely. And we can see that the obturation, the sealing material is sort of pushing into this space. And we're going to prepare the palatal accessory cone, shall we say it. Same again, dip it in isopropyl alcohol. We're going to sort of blow off the excess. Sometimes this makes a bit of a mess. And then I think in this case, what I'm going to do is I'm just going to get my obturation. I'm just going to fill this tooth with lots and lots of sealer. I'm happy to you know, I don't want any voids, so I'm not taking any chances. So I'm going to get our accessory cone. I'm going to put this or fit this nicely to length, and hopefully we've used enough of the GP, we've enough of the sealer, and this is going to create like a nice monoblock appearance on the radiograph. So we're just pushing it nicely to length. Again, we're looking for the point where we've cut it, because we know that now this is sitting at the point where we're happy with on the cone fit radiograph. And we can see now we've got two nicely fitted cones here. We can see that dentin bridge, which looks fantastic. We're then ready to cut off the excess. I'm going to get my heated plugger. And in this case, one of the heated plugger has been bent and broken for a while, and I don't like to use it very much. But actually in this case, because it's got like a wide curve on it, in fact, cutting off the excess through the dentin bridge using this broken or this bent heated plugger is actually quite advantageous. And the great thing about, rather than cutting the GP cones downwards or vertically, if you cut them across, you're less likely to pull out the GP cones once you're removing the excess. And of course, you know, you pull out a GP cone, it's kind of a bit of a risky business. You know, if you do pull out a GP cone, do you just push it back in? Do you reshape? Do you retake it? So it's all difficult. So the best thing for you to do is just to do the most safest option, and that's just to shear it off from underneath the bridge. Once we've sheared off the excess, what I'm going to do now is, again, it's just a quick succession of final compaction with Mach 2 pluggers, removing a little bit more excess with the heated plugger, bit more compaction, and then you know, that essentially is the root canal done. And now we're ready to do our final restoration. Again, you can see here that I'm just giving the coronal GP a bit more of a push down. I always make sure I warn the patient I'm pushing it down, because it can be a bit worrying sometimes. We're then going to put a final restoration. I'm going to wash away the Bioceramic with just water, and then I'm going to use a matrix band just to place a final restoration. I suppose an argument with the matrix band, especially I'm not using a wedge here, is the contact point, especially between the upper 5 and upper 4. But you know, I'm happy with this relatively. I'm using Scotchbond here. This is a self-etch bond. I'm going to make loads and loads and loads and make sure I've got loads of bond in there and give it a bit of a blowout. And then, you know, I like to use SDR. Again, if you're using a lot of my videos, I like to use SDR. But in this case, I feel like the sort of the bulk properties and the flow properties of this composite is really good in this situation, essentially because it's really difficult to access and get the composite compacted in all the little nooks and crannies of this coronal restoration. So essentially I'm just using this SDR in small increments, make sure it flows into all the little nice nooks and crannies of the tooth, and then we just give it a little bit of a polish up. And we look at the post-op radiograph. We've got a nice little sealer puff at the end. I don't like to have a sealer puff, but this is a nice sealer puff. We've got a little bit of a lateral sealer puff as well, and I suppose you could see that the apical inflammation on this x-ray, we can see that it moves quite far up the tooth, and it's kind of a bit of a lateral one as well. You can see a little bit of sealer there, and also you can see the dentin bridge, and also what you can see is that you can see that the SDR has flown nicely into the whole coronal aspect of this tooth, and overall really nice result. We spend lots of time on a root canal, and then when we get our post-op radiograph, this is what it's all about. This makes you want to come to work in the morning. Nothing worse than getting a post-op radiograph and it looks terrible. And overall, we just give it a little bit of a polish. Patient was super happy. There's an argument to say, does this tooth need a crown? I'm not entirely sure. I'm going to leave that to referring dentist and the conversation that he's going to have with the patient. And overall, everything looks great. Listen, if you love the video, you love the channel, please like and subscribe. If you have any comments or criticisms, or you think something could have been done differently, please comment in the section below. Join the membership program if you want early access to content and exclusive content, and I will see you in the next video next week. Bye bye.